I want to introduce our presenter, who is Bob Tero. As I said, he's the Assistant Director of Respiratory Care at Saint Barnabas Medical Center. He is also a lecturer for the pulmonary module, respiratory care practitioners, and critical care nurses for the Robert Wood Johnson Barnabas system. He is a clinical consultant and presenter for Pulse Flow Ventilation Percussionaire Corp and the Byrd Institute of Pulmonary Care. He has authored publications on ventilator weaning, pulse flow ventilation, and high flow therapy. And he has also played a key role in innovating the neonatal application of high flow therapy and has been actively involved in clinical applications of high flow therapy in all age groups since the early 2000s. Without any other further delay, Bob, I'm going to turn it over to you to start our presentation.
Thank you, Nicole. Greetings to everyone, and good afternoon to those in the east and the west. Good morning. You guys are still in the morning time there. And hope everyone is doing well, and thank you for joining us today. I'm always honored and delighted to be part of a webinar, so thank you for having me again. I know this is our second one. And although my experience on the use of high-velocity nasal insufflation extends through the neonatal, pediatric, and the adult critical care, today's presentation will be focused on the application of HVNI, in short for high-velocity nasal insufflation, specific in the emergency department setting. Just as introduction, HVNI is a form of respiratory support using high-velocity gas flow through a nasal cannula that offers a comfortable and effective alternative for our patients not tolerating BiPAP or other non-invasive positive pressure ventilation using a mask interface. Before we proceed, I'd like to go over our learning objectives for this presentation. We're going to discuss the application of HVNI in the emergency department, and we'll share some case studies we have from our friends down in Athens Regional Medical Center in Georgia, and understand the mechanism of action behind the application of HVNI. Learn how to implement HVNI protocol in your ED, in our ED, and review current supporting clinical data on HVNI. Next slide, please. In the spirit of full disclosure, I am a clinical consultant, and I do utilize the Vapotherm at the institution I currently work at, and I will be receiving financial support from Vapotherm to give this presentation to you today. Next slide, please, Nicole. Looking at these photos, I believe we share the same types of patients in respiratory distress and respiratory failure in our respective emergency department. Here we see our typical looking patient just by the look of them, or just because they're having, or they appear to be having difficulty breathing. Our frequent flyers, such as our COPDers and CHF patients, at least in our hospital and our ED, historically we treat these patients with either conventional or those that are having a little bit more difficulty gets treated with NIPPV. And in worst case scenarios, we do intubate and admit them to the ICU, something that we all strive to avoid, and at times unsuccessfully. And in recent years, however, we have learned that placing a portion of these patients on high-flow nasal cannula, we were able to treat the signs and symptoms of a wide range of respiratory distress, successfully averting more invasive support and ICU admissions. And often these patients present themselves in the ED at various levels of difficulty as their acuity increases, as many of these patients can sometimes get worse so quickly. So does the invasiveness of the intervention. Although the application of common high-flow nasal cannula systems offers some practical solutions for us and a wonderful tool to treat patients with mild to moderate distress, kind of a in-between therapy with NIPPV as highlighted in light blue there. highlighted in dark blue, high velocity nasal insufflations quite have a different effect in our experience, and it offers a far more clinical advantage than just humidity and flow, a true practical alternative to those not tolerating NIPPV. And here's how we see it. This technology delivers very high velocity gas and offers objectives beyond just reduction of work of breathing, reduces inspiratory resistance while meeting and exceeding peak inspiratory flow of our patients, being that the majority of breathing resistance occurs in the upper airway. Patient CO2-filled physiologic dead space can easily be purged on exhalation, making ventilation a bit more efficient. And finally, it produces mild distending pressure that can be crucial in some of our patients in need of splinting an airway or splinting an alveoli. And all of the above are really best accomplished when breathing gases are conditioned that can avoid mucosal damage and ultimately improve the condition of our patient's lungs. But something to be mindful about, please note that some of our patients will always need or will need pressure-based NIV, such as your severe CHF that's in fluid overload. These patients typically will require pressures, as many of us may believe, to push fluid back into circulation, and which is crucial in maintaining a sustained FRC more consistently as compared to HFT. It does not equate similarly with respect to this application. Next couple of slides, I'm going to share two examples of case reports from our friends at Athens Regional Medical Center. And again, please note that individual results may vary from institutions to institutions, so it's extremely important that we as clinicians recognize when it is appropriate to escalate respiratory interventions in situations of increasing work of breathing, especially those patients with persistent hypoxemia and hypercapnia. So here's a patient who presented in the ED with elevated work of breathing. These guys placed the patient on oxygen via nasal cannula attached to an unheated bubble humidifier, ran at 15 liters per minute. I'm particularly not a big fan of this, but we do have physicians in our facility who also like to use this, and we haven't used it recently. And in Athens, they found that this was not clinically effective, something that's, again, something we sort of experienced ourselves. And they found that on the ABG results that was drawn. And based also on their clinical observation, it was obvious that the patient did not have any improvement in his difficulty breathing, as well as an improvement in hypoxemia. So the RT initiated the patient on high velocity nasal insufflation, set at a moderate flow rate of 25 liters per minute, and started the patient on 100% FiO2. Within just 1 minute, here we can see that the patient's SpO2 improved quite dramatically and remained above 92. In addition, there was a sustained drop in his systolic blood pressure, indicating an improvement in his cardiovascular workload, and also a 15% decrease in respiratory rate for the remainder of his ED stay, indicating an improvement also in his respiratory status. Along with the HVNI, the patient was also given Lasix and was placed on nitroglycerin IV. From the patient perspective, according to the nurse's notes, he indicated the patient felt better and was having an easier time breathing. And eventually in the ED, the patient was titrated up to 30 liters per minute in order to allow the FiO2 to titrate down to 80% to maintain an acceptable saturation and patient comfort. That patient remained on HVNI throughout his completion of his ED time and was eventually moved to the ICU for continued diuresis and to address his complaint of chest pain. And here we can see the patient is doing pretty well, and HVNI provided a decrease in work of breathing over conventional oxygen therapy, and may have turned this patient around mainly because of the, again, the application of HVNI, and may have been a candidate for more invasive interventions such as NIPPV or mechanical ventilation. And therefore, the complexities and the associated hazards of non-invasive ventilation may have been avoided. And interestingly, this patient quite responded positively so quickly and was able to breathe synchronously and comfortably, adapt to this therapy quite, again, easily. And here's another interesting one that they shared with us. A patient with history of COPD and CO2 retention who was just recently intubated within a month prior to this admission, I believe 18 days prior. And what they saw from this patient on admission, they noted tachypnea and nasal flaring, pursed lip breathing, bilateral wheezing, and wet cough, something that we see regularly on our COPD patients. Blood gas was drawn, and the patient was started on a moderate flow rate, again at 25 liters per minute. And this particular patient, they only started at 60% FiO2. And looking at the blood gas, what therapy do you think we are likely going to initiate? And in this particular patient, initially the patient was going to be placed on an NIPPV, but the RT suggested and may have insisted on high velocity HVNI, and that's where the patient ended up. So let's take a look at the patient's response as soon as the patient was placed on HVNI. Here you can see that the application of HVNI resulted in a reduced minute ventilation by way of reduction in respiratory rate. Here you can see from 36 it dropped to as low as 22 breaths per minute. The CO2 elimination from the dead space improved the arterial CO2 by allowing the patient to breathe more efficiently, and you can see that the pH went up from 7.28 all the way up to 7.41, and the arterial CO2 was reduced to 53, which is typical for a compensated COPD patient, as evidenced by his bicarb of 33 milliequivalents per liter. This reduces worker breathing, likely averted respiratory muscle fatigue, and subsequent invasive support. These are the type of patients that can be treated with HVNI, and something that we've been doing in our ED as well for the past couple of years because of its unique ability to flush the CO2, expired gas, from the dead space. And in this case, here is a patient that entered the ED in acute respiratory distress and would typically be placed on pressure-based NIV, and something, again, that based on the poll, you folks think the same way. And this one is treated successfully with HVNI without having to be treated invasively or other NIPPV. Unfortunately for us, these patients are not quite unique to Athens Regional Medical Center. They are actually quite common in our ED as well. So the increase in high flow therapy in our ED has significantly reduced the need for non-invasive ventilation. So what makes HVNI different compared to other high flow nasal cannula systems? So let's take a look. The idea is to deliver high velocity, optimally conditioned gas flows through a small bore nasal cannula in an effort to flush dead space of expiratory gas. Here you'll see the dead space is converted into a reservoir of fresh gas that facilitates oxygenation and ventilation. In a slowed animation shown here, we can see vortices created in the upper airway, flushing expiratory gas and replacing it with fresh gas, and ultimately making breathing more efficient. And to better understand how velocity flows impact oxygenation and ventilation, let's review some basic respiratory physiology. In the adults like you and me, at least 30% of our inspired volume is dead space. In neonates, it's actually closer to 50% due to the relative size of their bigger head in proportion to their smaller body. At the start of each new breath, we rebreathe CO2 from the previous breath, which is last air in, and it's going to be last air out. It's going to be first air in. And as the gas composition dead space changes, it will naturally impact our ventilatory efficiency of our patients. And here's a formula we all are familiar of, where minute ventilation, the volume of gas we inhale or exhale over a minute period, is our tidal volume multiplied by our respiratory rate. Alveolar ventilation, however, is the same equation, but adjusted for our dead space by replacing expiratory dead space gas with fresh gas. Our tidal volumes becomes more efficient for improved work of breathing. This may explain why the drop in CO2 from the two patients we previously described, despite the decreasing respiratory rate and over a period of time. Additionally, high velocity flows reduce inspiratory resistance and can allow a patient to breathe from their dead space rather than through it. So how do we get these accomplished? I know it's I'm going to mention this not in a particular order that you see in your slide, but first and foremost, the patient must be spontaneously breathing and must be alert and oriented. And that goes without any non-invasive ventilation that we provide for our patients. And to achieve high velocity flows, we must have the correct small bore cannula that does not obstruct or occlude the patient's nares. And we'll talk a little bit more about that shortly. We need to apply the appropriate volumetric flow and velocity for an effective purge. I'll cite you an example. I was once called to a bedside of an adult male patient on a high-flow nasal cannula. This patient was actually admitted to the floor due to exacerbated CHF. As soon as I walked into the room, I immediately noticed that he was on a tight-fitting large-bore cannula, and he appeared to be uncomfortable. He did complain about the discomfort. We weren't actually sure what caused the discomfort, and the covering RT came and basically just suggested, how about if we try a smaller bore cannula to see if it's going to make a difference. And it was quite apparent that as soon as he was switched over to it, he responded quite positively with a noticeable change in his work of breathing and comfort. So simple changes that could make a difference for our patients. In this section, I'd like to share the rationale of why we use HVNI and RED. Here's a nice diagram of how velocity works, where volume of flow is the amount of flow that passes over a unit of time in liters per minute. The speed at which that flow travels is what's called velocity, and it varies inversely with the cross-sectional area of a tube. The smaller the cross-section, the higher the velocity of flow, and higher velocity flows at the same volumetric flow is part of why this technology is able to flush dead space more efficiently than other large bore tubing systems. Let's take a look at an example of a garden hose with or without a nozzle. With a nozzle, or by placing your thumb over the hose, immediately we'll notice a change in the velocity of the water without even changing flow. Which one do you think will be better at washing a dirty or a soapy car? And of course, it's going to be the hose with a nozzle over it, or a thumb over it, will be more efficient in washing a dirty car. Excuse me. Just as a high velocity flow will be more effective in flushing expiratory gas from dead space. Here we can see that the small outer diameter cannula allows for expiratory gas egress, which allows the retained CO2 to flush out of the dead space and functionally reducing dead space and eventually patients' breathing. The larger the outer diameter, the more restrictive the cannula will be, which can result in less gas being flushed out from the dead space and actually creating more discomfort than good. So that's something that we have to be mindful when we're selecting the proper cannula size. And additionally, this technique can increase airway pressures and may potentially result in increased work of breathing. As seen with a male CHF patient earlier, another event, I was actually responding to a call as well from a nurse of a female patient on high-flow cannula. That patient was reported to be desatting. So immediately I run up and, as similar to the earlier example, This patient was also on a tight-fitting high-flow cannula. In fact, the circuit had actually popped off from the heater chamber. And again, this problem was easily resolved by obviously reconnecting the patient and also changing the cannula to a smaller size. At the hospital where I work at, we do use not only the Vapotherm, but we also use the OptiFlow from FNP for more of our stable patients, and actively use our Vapotherms for our sicker ones, whether it's the pediatric, neonate, or adult. And in the image, you can see how the inner and outer diameter will impact the velocity and ability to flush gas out. The animation here actually shows that it demonstrates how expiratory gas is purged effectively from the dead space. And something to consider is time. Time is critical because as respiratory rate increases, the opportunity to flush CO2 out of the dead space becomes significantly reduced. The advantage of high velocity is that it introduces this turbulent energy into the patient's nasopharynx that facilitates the mixing of gas, which is crucial in expediting the purge of CO2. And therefore, the system that delivers the fastest flow will be the one that's faster to treat the signs and symptoms of a patient in respiratory distress more efficiently. Note in this graph, it demonstrates the relationship between breathing rate and expiratory time. A patient in respiratory distress typically allows less than a second for a complete purge of the upper airway, and actually shorter, significantly shorter in our smaller populations, the pediatric and neonates as well. So velocity is real key for an effective flush, especially when time is limited. Here's further illustration of that. Here you can see the calculated differences in velocity between the small bore nasal cannula reflected in blue line and as compared to a large bore adult high flow nasal cannula reflected in green. At 60 liters per minute with a large bore cannula, it can only reach a velocity of 20 meters per second, while the HVNI technology set at 40 liters per minute is able to achieve a velocity of 60 meters per second, at least 3 times faster than the large bore. So for the large bore to even come close to the HVNI velocity, it would have to be set at 180 liters per minute in order to achieve that type of velocity. So it's really, really quite a difference between the two technologies. So it's that unique aspect and the design of this technology that allows us to deliver a much higher velocity, which is crucial in treating our patients in respiratory distress. And this is my favorite right here. We can't be delivering gas to our patients dry anymore. It has to be optimal and it has to be conditioned well. So it's my favorite application, which is humidifying high flows. And here in this graph, adapted from a work of Williams and colleagues showing mucosal function as a function of inspired humidity. Ideally, when we deliver gas to our patient, it should be at core temperature and 100% relative humidity in order to preserve maximum mucociliary transport and overall integrity of the lungs. At lower levels of inspired humidity here, we can see that's moving away from 44 milligrams of water per liter. Water can easily evaporate from the mucus and periciliary fluid and resulting, sorry about that, an increased viscosity and loss of mucociliary function. In other words, this can lead to thickening of secretions and possibly atelectasis in some of our patients and eventual cell damage. So in this section, I'd like to share how and when we can use HVNI in our ED. The good news is that high velocity treats the signs and symptoms of respiratory distress and not necessarily just the primary underlying disease state. Here you see a list of respiratory systems and conditions that may be addressed and corrected with HVNI. Examples are general dyspnea, hypercapnia, patients with refractory hypoxemia, increased cardiac workload, and increased work of breathing. These are also associated with conditions such as acute COPD exacerbations, mild to moderate congestive heart failure, asthma patient, pneumonia, bronchitis. Most recently, in the past few years, we've used a significant amount of HVNI with our RSV population, where it has significantly reduced our need for NIV, CPAP, and even mechanical ventilation and influenza as well. Next slide, please. Again, as a reminder, cannula should be sized not to include greater than 50% of the nares, although that's more like an art than a science, but we all have to strive for that because that's crucial in ensuring escape of CO2 from the dead space. The lesser the escape, the more difficult it is for the patient to make breathing more efficient. Cannula prong should be separated enough so not to pinch the nasal septum, and we all strive to prevent any septal breakdown. So just something that you have to keep an eye on when you're treating patients on high flow. We should allow the system to reach at least 33 degrees centigrade before connecting the cannula to the tube and applying it to our patient, although in some situations we may not have the luxury to do so and we have to connect the patient. But if all possible, it's best if we could keep it up to 33 degrees before hooking up to the patient. So when would we initiate HVNI? I know you can see here that represented in the clinical guidelines of a PO2 of less than 80. In our clinical practice, we are more lean towards a PaO2 of 60 mmHg or less, SATs of less than 90%, CO2 greater than 45 with associated tachycardia and tachypnea or shortness of breath. And over time, we've learned that the aggressive use of high flow rates with patients that are in distress is the most effective. Now we're looking at 30 to 40 liters per minute, and obviously titrating it to patient tolerance. And while some may tolerate high flows, others may not. So you really have to be open to titrating it. So feel free to do so. Flow rates are then titrated down for patient comfort and tolerance, and to always ensure that we maintain the clinical effectiveness of the therapy as well, because you don't want to overdo titration and now you're losing the effects of the high flow therapy. Here are some of the supporting clinical data to this application that I'd like to share with you. Here we have a study that was conducted in 23 centers across Belgium and France between 2011 and 2013, actually published in New England Journal of Medicine in 2015. While these data are not specific to the ED, to the emergency department, they are in relevant adult patient population that is commonly seen in our ED as well. A total of 310 patients were randomly enrolled into 3 groups of patients with acute respiratory failure admitted to the ICU. One group was placed on standard O2 using a non-breather mask. Another group, high flow nasal cannula using a Fisher and Paykel humidification system. And the third group into the ventilator non-invasive ventilation group. The enrolled patients were selected based on very strict and specific criteria. Patients must have absence of chronic respiratory failure, respiratory rate of more than 25 breaths per minute. The PF ratio has to be 300 or less, and PCO2 cannot be higher than 45 mmHg. And again, it's very obvious that it's purely hypoxemic respiratory failure patients that they're treating. Hypercapnic, or including in the study, and hypercapnic patients were specifically excluded, including acutely exacerbated COPD, asthma patients, and CHF patients. Although many of us will agree, along actually with hypoxemic respiratory failure, these are the vast majority of patients that are very costly to manage. However, this study specifically only included patients with acute hypoxemic respiratory failure. In fact, many of these patients were diagnosed with pneumonia as a primary respiratory condition. The study's primary outcome was to look at the proportion of patients intubated within 28 days. Interestingly, the results did not differ among the 3 groups with respect to rates of intubation However, the crude in-ICU mortality and 90-day mortality and ventilator-free days differed significantly among three groups, high-flow nasal cannula being significantly lower in mortality and higher in ventilator-free days, particularly in patients with severe hypoxemia where PF ratios were less than 200. And the authors concluded that the patients with hypoxemic respiratory failure treated with high-flow nasal cannula had improved survival rate as compared to a standard oxygen and non-invasive pressure ventilation. And here we have a pilot data from Russell Graham, from a friend down Texas, and worked with his colleagues from 3 of their emergency departments of University of Texas Health System. These folks have found successful use of high-flow therapy in the ICU setting, so why not try the application in the ED to avert intubation or NIV? So they were curious about that application, and they, using a technical assessment form, looking into what clinicians' perceptions are as far as patient diagnosis, staff ease of use, and where these patients would end up after being treated with high-flow therapy. And what they found was that high-flow could offer comparable symptom relief to treat a variety of patients in respiratory distress in the ED. They also found that they could transition these patients to lower acuity areas within the hospital, allowing for reduced ICU admissions and ultimately cost. And something that I think we all can share as far as reducing costs and reducing ICU admissions. Here you can see the presumed patient diagnosis found by their clinicians. When combined, 60% of these patients had a presumptive diagnosis of COPD and general dyspnea. So where did these patients end up? As far as disposition, upon review of a patient decision on patient disposition, half of these patients were actually weaned to a therapy that allowed them to avoid patients moving into the ICUs. And in fact, 12% of the patients were actually discharged to home. So they collaborated with a larger group of hospitals where they conducted a multi-center evaluation. This is actually published in a Respiratory Therapy in 2015. And they used the same protocol shown in the previous poster by Russell Graham and colleague, but now expanded it across 6 centers in 4 states, and they were able to collect a total of 128 assessments from this study. And not surprisingly, the investigators observed the same outcomes as the abstract, again, presented by Graham and colleagues. Next slide, please. The assessment showed the usefulness of HVNI in the ED setting, pretty much, again, similar to the previous one, where COPD and general dyspnea were, again, the most common presumed diagnosis, and suggesting that HVNI can be used to treat the signs and symptoms of respiratory distress for a wide range of patients. Next slide, please. And in this mixed percentage, we can further see the breakdown that 12% of the patient presented with hypercapnia, 36% with hypoxemia, 41% with increased work of breathing, and 11% combined with type 1 and type 2 failures. Next slide, please. And as far as the patient disposition, it shows similar to the previous data in that half of these patients were able to be sent to the floor instead of ICU. And it's, again, something that we, too, from our hospital point of view, is trying to achieve. So in summary, high-velocity nasal insufflation from a small bore high-flow cannula shows promise that it can effectively facilitate CO2 clearance by purging the upper airway of a patient, and a small window of time between breaths in patients with respiratory distress. And what we've also found that the earlier this is applied, it seems like we are getting better results and better outcome. High velocity is reported to be comfortable and well tolerated and offers a more adherence to therapy. Again, something that we have experienced at our ED as well. And with the appropriate patient selection, HVNI can be used successfully in the ED based on what we just presented from the previous slide as alternative to pressure-based NIV. So at this point, I will end my presentation